Hello, welcome back to our YouTube channel. It's me, your Build and Breathe trainer, Emily, and today I'm joined by a very special guest from across the pond, Dr. William Clark. So he is a spinal surgeon over in Oklahoma, and he asked to come and chat basically about new types of surgery, what's going on with surgery, whether or not to go ahead, how to choose your surgeon, all of these really important issues. So we went straight into it. So I'm just going to play it and I will leave you to enjoy.
Can you tell us a bit about your story? Because I find it very funny. Obviously, most of us get a scoliosis diagnosis and we're thrust into the world of scoliosis, but I guess you've chosen to go into it. So how did that happen? Why was it your specialty?
Well, I grew up here, went to med school here in Oklahoma, and they had a really strong pediatric scoliosis department. So I was already enmeshed with scoliosis, really fascinated with it. When I went to Duke for residency, I would have thought I would have done sports, but then I found it like when they would go, it hurts when I throw the ball. And I would go, well, don't throw the ball. But then when I was spending time with kids and even adults with spine deformities, they were just so they were so the surgeries were big, the impacts were big, the risks were big. You could see it. There was before and an after. And it was like I really enjoyed it. And the people that I worked with at the Shriners hospitals, at Duke, at the Scottish Rites, and the patients, it was just really valuable. And I think that it was that I had the opportunity to make such a big impact, on maybe a kid's life to brace them and avoid surgery, or reassure them that you're fine and that your curve is mild and that you can do anything that you want. Or if it was operative, I wanted to make sure that we were doing the right surgery to the right kid for the right reason and doing the right fusion levels and setting them up for not only success today, but also as young adults and even on down the road. And I think there was a huge need. I don't think that there's a lot of people going into spine deformity. And so it's kind of a fun niche of a niche of a niche,
Yeah.
not only in orthopedics and doing spine, but doing spine and doing deformity is like a fun place to be. And so I wake up thinking about it. I go to bed thinking about it, just something that I really enjoy and truly passionate about. So I feel very fortunate that like I don't think I go to work.
Yeah.
It's like really nice that I get to come here. I love talking about it. So when someone said, "Hey, can you do a webinar and talk about scoliosis surgery?" I was like,
Yeah.
"Sure, yeah."
Oh, good. Me too. Okay. You mentioned orthopedic. Is there a difference between orthopedic surgery and the neurosurgery side of things?
I think so, and I think
Yeah.
it kind of dates back, even if you can tolerate my history here.
Mm.
Scoliosis, or I'm sorry, orthopedics um, was derived as a specialty, as an entity for the treatment of polio and the treatment of children with scoliosis.
Okay.
So that's its lifeblood. And if you know what ortho means in organic chemistry is straight, they're when the carbons are across from each other, and pedics is kids. So orthopedics is straight kids. And so it's really where orthopedics as a whole was derived in the evaluation and treatment of kids with scoliosis. And so it's kind of, I think, been more of an orthopedic related thing. We have, I think, as an orthopedist, you have a little bit more fund of knowledge of general musculoskeletal, hips, knees, and so forth, alignment. And our training is a little bit more streamlined towards deformity. There are neurosurgeons that do deformity, but they're a little bit more the rarity than the norm. I would say most of the spine deformity surgeons that I know, and there's not that many. I mean, as a whole, there's just not a whole lot of people that are just super subspecialized. And I'd probably say 80% of them are orthopedics. I could be proven wrong. Probably only 20% are neurosurgery. Neurosurgery does brains and tumors and
Yeah.
aneurysms, and they do spine surgery. I would say that probably 90% of spine surgery is done by either ortho or neuro.
Yeah.
There's 10% that I think is these major deformities that are ortho, and there's probably 10% that are like intradural tumors that I would say those are neuro, and I refer those on. But I think orthopedists are just a little more equipped as far as their upbringing, their fund of knowledge, the orthopedic training to be doing it. But there are very, very good neurosurgeons that do deformity.
Okay, no, that's really interesting. It's interesting to see, I guess, how you'd approach things from a slightly different point of view as well. Obviously, as a patient, we just go in and whatever happens, happens. So it's interesting to see from that point of view. So obviously, you've been doing this for a long time. How long would you say you've been doing this as a specialty?
Well, I've been out in practice, meaning done with med school, residency, fellowship for 15 years.
15 years. And how's that surgery changed in 15 years? That's a long time for medical technology to develop.
Yes, and that's such a good question because I just said today that I was talking to a patient and was telling them that you could have surgery today, and the benefit of waiting is that we'll be doing it differently. And they were like, oh, what do you mean? And I'm like, well, I hope I look back at what I'm doing now and think that, wow, I used to do it that way, that we're going to make advances and things are going to change moving forward. And I said, because when I look at how I did things 10 years ago, it is very different. And I would say probably one of the biggest differences is this collaborative team approach. Like we have an entire complex spine team that sees and vets and evaluates and helps me plan and coordinate surgery long before we do it. And at a multidisciplinary meeting at the hospital, and just the way that I talk and plan and orchestrate and coordinate surgery and the things that we look at, that their mental health, their social situation, how they look at themselves, a lot of these things we didn't really pay attention to before. Like it was like you have a curve that's X degrees and we're making it Y. Well, now we're looking at all those other tangible factors that are the difference between a good outcome and a bad outcome. So I think the perioperative management, I think our OR is set up and structured to be way more streamlined and efficient. We have the same scrub techs, the same nurses, the same anesthesia. We've streamlined the postoperative care. Like there's protocols in place that you're to be doing X, Y, and Z, and the nurses know that you're supposed to be up at this time and eating at this time and home. And then the way that we manage, maybe through more of an ERAS, which I think is early recovery after surgery, the way we're using multimodal medication and non-narcotics and bowel regimens and walking, and so it's really changed the landscape. I mean, I went from first out in practice, I remember we used to tell kids that you can't do anything for a year.
Yeah.
And then I had a girl who rode horses and she was really into jumping, and she was crying because she wanted to ride her horse and jump at 9 months. And I remember letting her and having this anxiety that I was letting her jump horses at 9 months. And then today I let kids go back and play competitive sports now at 3 months. So we've made this huge shift from how I managed them when I first got out to now. And we've really, really pushed the envelope as far as their hospital stay and what we're allowing to do. Kids are going back to school like 2 weeks after surgery as opposed to much longer.
Yeah.
Because I do a bunch over Christmas break, and they can just miss Christmas break, and all the kids go back to school and not miss any school.
Yeah.
If you set that expectation.
Yes. Okay.
If you tell a kid you're going to lay around in bed for 6 weeks, you're going to be in horrible pain, and you're going to take pain meds, and it's going to be the worst thing of your entire life, that's exactly what will happen.
Yeah.
If you tell them, hey, we're going to get up, we're going to move, we're going to walk, we're going to limit this, we're going to do that, we're going to go here, we're going to go there, you're going to be in school in 2 weeks, guess what they do?
And
They
that's
do.
so important if you think about feeding into that kind of emotional state as well. If you wrap yourself in cotton wool and you're told that you're fragile and you can't do anything and you're going to bend and snap, of course you're going to spend the rest of your life in fear and you're not going to put yourself out there. And I think I had that, my surgery was 10 years ago, and it was very much a protective thing. And I didn't go back to school for 3 months. I didn't go back to dancing for 6. And I've always been nervous about falling. And I think it does stem from the language around the surgery.
Mm-hmm. Well, and that was kind of some of the language 10 years ago, and that's some of the things that's changed. But it really only changed out of happenstance. I'd have these kids come back and go, hey, I went tubing at the lake this weekend. Is that okay? And I'm like, you did what? And they were fine. That's okay. So I mean, it's just getting the confidence to know that you can do things differently, and trying to change the paradigm and change the dogma that is surrounding it. There are still a lot of people that still function in that way, that are still having those conversations, and the length of time and the recovery is that, and they're saying those things in that way. And there's still kids today that are still missing school for 3 months and not returning to sport for 6 or 9. And that's why I'm trying to take this opportunity to be like, and now it doesn't really have to be that way. You can really expedite things, particularly in teenagers, and allow them to return back to things pretty fast if you're doing the right thing the right way and the right kid at the right time.
Because our bodies are amazing. Our spines are so robust, aren't they? I think that you think when it's curvy and you've got metalwork in there that it's brittle and it's fragile, but we're amazing. Like the human body's insane.
Exactly.
Yeah,
And kids are amazing.
yeah,
But
that's
even
true.
even in my adult world, we've really changed the way that we do things. Um, and that might be another question that you didn't ask that you might not even know about, but the difference between ortho and neuro.
Yeah.
But there's a big difference between ortho peds and ortho spine guys.
Okay.
Because there's a lot of guys that do orthopedic peds and they do ped scoliosis. And then there's a whole subset of people that are orthopedic spine that do peds, young adults, older adults, and so forth that just do spine. So there's a
Yeah.
big discrepancy or difference in that too. That'd be a whole nother conversation.
Yeah, there's so much to delve into. Well, you got my brain ticking of something you said before about the actual process of the surgery, and that if you look back 10 years ago, it's changed a lot. So I am aware that there was Harrington rods used a long time ago. I've had a rod infusion method, and we're seeing VBT coming in. Can you talk us through all of that and what your experience is with those?
Yeah, so I think it's been pretty fun because, well, I said I've been out in practice for 15 years. My training in my med school kind of took me back even 20 plus years ago. And I remember the head faculty in med school that was using instrumentation was CD instrumentation. It was Claudel Dubussy, which were two French guys that came up instead of 2 hooks and a single rod for Harrington rods. They came up with this multiple hooks, and it was like really really innovative, and it was neat seeing him plan and orchestrate. We're going to put an up hook here and a down hook here and do this there. And then as I move forward, when we were doing hybrid constructs, so we were doing hooks up top and then pedicle screws down low. And then there was a whole group of people, Koreans, that were doing all screws. And there's like, oh, well, that's crazy. They're doing all screw constructs. And so really my practice kind of has evolved throughout that whole time. And now we're pretty much doing all screws. I think some things that have really changed has been, instead of just paying attention to the coronal plane, like how we're making the curve in the coronal plane, straight, we're really paying more attention to the sagittal plane, and a lot of it's about restoring normal thoracic kyphosis so that kids have normal lumbar lordosis. Because if you follow these kids out 25 years, that if you put their spine really straight, that it leads to a really straight lumbar spine and can lead to problems down low. Whereas if you create a normal thoracic curve, they have a normal lumbar curve and they tend to do better. So the focus hasn't been so much on the straight, perfect plane. I think there's been a lot more about selective thoracic fusion versus, fusing both curves. So identifying what curves that you can just fix one of the curves instead of both. When I go to meetings, all of the debate isn't like whether this kid with a 60-degree curve needs a surgery. It's the fate of the curve that you didn't fix, and where do you start and stop?
How do you
There's not
decide
much
that?
well, it's challenging, like I decided on their standing film, where their sagittal plumb line fits, what do their bending and stretch films do, what's their body habitus, what is their expectation level, what are they going to return to sport, do I need to preserve these levels below, is it a person who can handle seeing a little bit of a curve there, do you need to cover both curves, do they hurt in their lower back? So a lot goes into it. You can't just have this singular parameter where you go, well, I always do that and I never do this, because this world, if you're having those conversations, you're missing out on the nuances, and the whole thing's a huge nuance. And until you look at them in that light and really study and plan and orchestrate where you're going to start and stop. So it's a real long answer to, you don't always really know. You can measure with the ruler, but we still cut with an axe. So you can still plan and orchestrate and think that you can go here. But in some scenarios I do this, and then some I do that, and some I lay them down and I go, wow, I would really like to stop short. Oh, I don't need to go that long, or I don't like the way this lined up. I planned to go here, but the curve below didn't correct like the way that I wanted.
Yeah.
But
Okay.
there's some basic rules that allow you to know whether you have to cover both or not, but it's all these gray debate ones that I think are really challenging.
Yeah. Good to keep your brain ticking though, eh?
Yes.
Is there any correlation then between pain levels and how much you would or wouldn't fuse? Would you expect that to change pain outcomes following the operation?
Yeah, surprisingly, when I show, like, when people go, what do you do for a living? And I show them like x-rays, they're like, oh, that poor kid, she must hurt. I'm like, nope, she didn't. Most don't.
Yeah.
Most kids have no pain. And so sometimes it makes them hard to justify doing the surgery. Sometimes when they do hurt, I'm like, why do they hurt? And do they legitimately hurt? There was a recent study that came up that actually, when you asked a lot of these kids, about 60% of them did report pain, but they didn't know it was really pain because it's all that they've ever known. So their perception of pain is different because they just lived that way. But while we have told people for years that kids with scoliosis don't hurt, we actually are finding that they do. And that if you do operate on kids who do hurt, most of their pain goes away.
Interesting.
So I think I've kind of let go of I used to really worry about the kids that hurt beforehand. And there are kids that have, that have painful scoliosis, which is different than just idiopathic scoliosis. And so you want to make sure that you want to make sure that you're ruling out reasons for painful scoliosis before you're just doing surgery for scoliosis.
Interesting. Okay, so lots of thought as to whether or not to actually go for it. Like how could a person individually make that decision? Because I see a lot of people come to me and they'll say, well, I've got this curve and this amount of pain, and my surgeon said we could just leave it and see what happens, or we could go for the surgery. What do I do? Like, how should somebody be making that decision?
Yeah, it's really hard because Well, because you're taking like a 13-year-old and you're asking, hey, will you predict the rest of my life? And will
Yeah.
you predict whether doing a surgery today would be better for me than doing it as a young adult or as later in adulthood? You're like, and that's really hard and really difficult to do to discern. And there's not great science and data and literature out there. And usually what I tell people is one of uh, the most important works as far as research was done like 50 years ago. It was done in rural Iowa, and they rounded up a whole bunch of people with scoliosis, and they drew a line in the sand, and they said, well, kids that are worse than 50 degrees, and we'll look at kids less than 50 degrees, and we'll follow them for 50 years. And they found that people with curves over 50 tended to have more pain, more dysfunction, more rates of disability, and their curves tended to progress, and they wished that they had it. And kids that were less than 50 degrees did just fine. They had normal rates of pain, normal rates as the general population. They had normal life, normal function, normal everything. So let's leave them alone. And so that's where
Yeah.
we've come up with this arbitrary line in the sand of 50 degrees. Now, there are some kids that are below 18 that have 40-degree curves that wish they would have had it done. And there's kids that are over 60 that did just fine. But how do you know?
You can't tell.
So
It's such a
I kind
hard
of
one.
have like a 50-degree rule. Some guys bump it down to 45 degrees as far as being like, well, most of us would recommend that you have surgery at that curve magnitude because we could predict that you're probably going to progress and it's going to be an issue for you down the road. And that addressing this at 13 while you're in your parents' house with little or no responsibilities, with your capacity to recover, I can fuse fewer levels. I mean, I can do T4 to L1 on a 55-degree curve in about 2 hours. They can stay in the hospital 2 days. They can come see me in 2 weeks, and I can send them back. So the things have changed dramatically from the
Yeah.
rural from 1950s. But should that change our indication just because you can do it better or faster or easier, you know? And so I have a lot of kids that come in with 30-degree curves and horrible pain and they want me to fix it. I'm like, no. And then you have kids with 75-degree curves that don't want surgery, and you're like, this isn't going to work.
Yeah.
So I like it when they're black and white. I like it when they're clean. I like it when kids come in with a massive curve because I can look at the kid and the mom and the dad in the eye and go, this really should be done. Because if we don't, it's going to get worse. Your kid's only 12. They have a lot of growth remaining. They already have a 75-degree curve. This is going nowhere. We can protect her cardiac and pulmonary function. We can do this, and that. This is black. No brainer. I can show this 100 neuro or ortho or peds guys or whatever. We're all going to do that surgery. I like the 40 and under curves. No one's going to operate on you, you know? And I think the problem is there's a lot of curves that fall into that 40 with pain, 48 degrees, I'm 51 degrees. What do you do with all those gray zone kids, that parents want you to give them some black and white answer, but there's not.
So
We
what
would
about
have to have 1,000 of that kid and do 500 that way and 500 that way and follow them for their lifetime and tell you that there was a difference in between the two, but you can't.
yeah. No, you can't ethically do that either, I suppose.
Right.
So I'm going to give you a hard one. What about this is something I've seen a lot. Somebody who's in their mid-20s and they've got a curve, say 40, 50 degrees. So it's not small, but it's not massive. And they're at the point where they've had it monitored every couple of years after they stop growing, and they're being given the choice, surgery or not. What would you say? I appreciate this is very hard.
No, I think this is great because I get these a lot. Like they escaped adolescence, and now they're like a young adult. Maybe they're a little bit more pain. Maybe they're a little more attuned to their self-image, and you're right. They're not a hard operative. I see a lot of those.
Yeah.
And, if I can talk you out of it, you probably shouldn't have it.
Okay.
And I spend a lot of time talking people out of it. The people that I can't talk out of it, that are doing it for excruciating pain, I'm like,
Yeah.
sometimes for me is a little bit of a red flag, that they have this like unreasonable expectation that their pain's out of proportion. I'm going to create a bigger monster by now. Not only do I have the need to fix your spine, but now I have the need to alleviate your pain. Well,
Yeah.
that's two responsibilities, and there's a risk that you could come back afterwards and go, I still hurt a lot. And I go, your spine's straight, and they're like, yeah, well, that 20-year-old didn't go back to school in 2 weeks, because you're usually not 20. My experience is if they don't do it before 18, that they go off to college, they get married, they have a baby or two, they have a mortgage and a car payment and this responsibility, and they're coming in at 30,
Okay.
33. So I usually don't have that 20-year-old conversation. It's a little bit older and they're having a little bit more pain, a little bit more dysfunction. Maybe they're progressed a little bit, and you're trying to navigate that kid. That one's kind of hard. I do have some of those 20-year-olds, and I just talk and explain to them, and I
Yeah.
go over the risks and benefits and the reasons, rationale. And the ones that I do, which are pretty infrequent, I stand behind, and the kids do well, um, because I think they're in the right mindset. That the role of the surgery is not for me to make their pain go away.
Yes, and I guess that's a huge consideration. It's amazing that the surgery is taking into account the kind of neuroscience of pain and how your emotions all feed into that, and that it is a whole person approach. It's not just about whether or not your spine's straight anymore, is it?
Yeah, that's how I look at it. Now, I don't know if everybody does, but that's
Yeah,
how
we're
I've
getting.
yeah, that's my nuance, and I'm constantly thinking about those type of things and how their perception. I mean, if you give me a kid who views scoliosis as an obstacle that they get to overcome and they're empowered by it, I think that's really potent.
Yeah,
Versus a kid who is victimized by it, right? And that they can't do X, Y, and Z, and they hurt
yeah.
because of it. They made me. Those are two different kids.
And I think it's interesting you can switch between the two. I definitely started after my op feeling very much like my life was over and I couldn't dance again. I couldn't do the things I wanted to. And I think it took me meeting other people with the fusion to see it as an empowering thing and to start to like my scars and to feel quite proud of overcoming it. So I think it is possible to get to that point. But yeah, it
Hmm.
takes time.
Right, but it took you a while.
Oh
And
yeah.
right. So I'm trying to cut these off at the pass. I'm
Yeah.
trying to expedite that process so that they don't have to go figure that out on their own, because not
Amazing.
everybody figures it out. Because
Yeah.
I have the benefit of seeing teenagers, young, even 65-year-olds that come in that had surgery as a teenager, and they are, woe is me, I can't function, my identity is wrapped up in this surgery that I had, or this curve that my parents didn't let me fix, or and I was told not to do anything and to wrap myself in bubble wrap, and I'm like, you didn't need to
Yeah.
do that. You would have been okay. This isn't that big of a curve. Just because you had scoliosis doesn't mean that it's a
Instructive.
100-degree curve that's gonna end your life.
Yeah.
There's a ton of education needs to happen. Um, and 10 years ago, we didn't have this opportunity to like
Yeah.
have a video conference and social media. And so we're utilizing some of these things to educate, because before it was only the kid in your school that's wearing a brace, or the kid in your school that had some horrible outcome from spine surgery, or what your mom's grandma's dog's best friend's neighbors told you, and
Yeah. No, it's amazing. Okay, so let's have a look at actually what the individual can do then, other than talking to people and feeling empowered and finding other opinions. What physically could I do, say, pre-surgery and post-surgery to maximize my recovery?
Well, I guess I would say pre-surgery is doing the due diligence to find the person that you like and that you feel
Yeah,
aligned with. I'm a huge proponent of a thin, fit, active, healthy, eating right, which we all should do, whether you have scoliosis or not. And so I spend a lot of time counseling on appropriate nutrition and exercise and not making this your identity. I tell a
yeah,
bunch of kids, I was like, have you ever seen the movie Men in Black?
yeah.
Yeah. And they have that little wand and like warp
Oh
some
yeah,
of them. Yeah.
yeah.
Like,
Yeah,
we're going to have this conversation today about your scoliosis, but I don't want you to carry it with you all day, every day, all night, every night. You're normal. Your
yeah,
goal as a teenager, you want to fit in. You're fit in. We have this issue. We're going to talk about it here, and outside of here, we're not going to be it.
yeah,
So, do I try to put patients in touch with other patients? I think having and sometimes it's hard because if they go find them on their own through Google or a chat room or something or other, they're all negative. If you go to
yeah,
Yelp and read about restaurants, the only people who write comments are horrible ones.
yes,
So if you go out there, you'll find some really negative stuff, and these people will come back and be like, "Oh my God, I found this." And so I try to line them up, a mom to a mom, or a dad to a dad, and a kid to a kid, where they can call and talk, and they have a similar curve and a similar grade and a similar social situation that they can call and identify and kind of try to give them a little bit of a tribe, to communicate with. I don't let them decide to have surgery the first time. We kind of come back, we talk about it more. I let them go home and think. I have them come back. So we do a lot of education. We also host a class. So before surgery, we have a roundtable in this conference room where we talk about door to door what surgery looks like at our institution, what they can expect, and we set all those expectations up. So those are all the things that I do kind of beforehand, mentally to nutritionally to physically, kind of prepare for it to the best of their ability. I want them involved. I want them asking questions. Why are you stopping at L1? Can you go to here? Will my hump go away? Like, and setting so you don't. Uh, will my shoulders be back to normal? And so I can go, maybe. I
yeah,
think so. It's my goal. It'll be better. You have to remind kids that the whole goal of surgery is to prevent it from getting worse.
yes, yeah,
The whole goal is to do it safely. The whole goal is to make sure that you're well balanced, meaning your head over your pelvis, your shoulders square. The whole goal is to do as few levels as possible, but not overfuse you, where you're fusing extraneous levels. And what I get it to is on the list, but it's way, way, way down the list.
yeah,
Um, and then I think afterwards is kind of adhering to a kind of a regimented post-operative course where you're up, you're walking, you're eating, you're
yeah,
staying on top of non-narcotic medication, you're taking stool softeners like Colace or Senecot, that you're drinking plenty of fluids, you're surrounding yourself with strong social support structures, you're getting out in the community. And we're trying to, like, I just saw a kid today who was 2 weeks post-op, and she's getting in the pool, and she was real excited about that. And she's real excited to get back into cheer, and she's driving, and she's going to go be with her cheerleading teammates. And she's going to be kind of getting into some of it, but not, jumping
yeah,
around and doing power tumbling, but where she's around her peers and not isolated, just in her house, like thinking about how my love sucks, that she's out doing things.
Okay, so kind of approaching it from physically, but also looking at the emotional side as well. That's really important. Yeah,
Mm-hmm.
oh, good. I like to think I know the answer a little bit to that one. Do a bit of Pilates. That's always good as well.
Oh yeah, I'm big yoga person.
Yeah.
Big. I went this morning, so I'm a big
Good for
fan.
you. Nice. So I've got one last question for you, which is,
Okay.
if you were going to give some advice to somebody who is going for a fusion, what would you say? No pressure. One bit of advice.
What would I say? I don't know.
It's a hard one. We can leave it if it's too much to think on the spot.
Yeah, I don't know. Maybe I don't know. Obviously, I don't know. I think maybe it's just true. Maybe I need a little more specific parameters to say.
Yeah. No, it's a very tough question. I'm just thinking if okay, say somebody is trying to make the decision of whether or not to go for a fusion. Is there one thing that you could say to them to help make their choice?
Yeah, I guess I would say that I would live in the now. I would live in the current, take the factors, the variables that you have at this very moment to help you make a decision, and whether that's curve magnitude or science and technology or pain and dysfunction, and you plot that on a chart and it yields, I feel really strong and good that this is surgery is the best thing for me to do today. And if you go, God, my curve isn't that bad, my pain and dysfunction isn't that poor, isn't that low. And I think that there's value moving forward and waiting to see what science and technology will have for me then you wait. And every time I see someone, I'm plotting those on this chart and I'm like, yeah, this is no brainer. You don't need surgery. Don't do it. Or this is really, this is no brainer. Everything is leading to your curve, your pain, your self imagery, what we're able to do today. This is, and so everybody has to do that inventory and ask themselves, where do they fall on that chart? And a lot of it I can't answer.
Yeah.
And so that's why you get the people going, well, they told me to go home and decide, because I can't tell you where you fit on there. I can help you stratify it. I can tell you what you would get today if you got it.
Yeah.
But I don't know what you will get tomorrow, or down the road. So and we're weighing things not just on a calendar. I mean, we're weighing things on a lifespan, and we're yielding a really powerful sword about this. You don't want to go to someone who just goes, yeah, okay, like just isn't thinking about all these things, at least in my opinion.
No, that's really interesting. And I think that'll be really helpful for people to hear, because I think you put a lot of importance on what the surgeon says. And so you want them to just say, yes, have the surgery, or no, don't. And actually, it's way more complex and you can't make that decision. So I think it's helpful to understand the actual reasoning behind that. Yeah. Interesting. I think it's amazing to chat to you. I cannot believe how much things have changed since I had my surgery. And I feel like it was such a medical thing. It was just come in, straighten your spine, stay in hospital for a bit and go home. And I never realised actually how much impact scoliosis has until I was a bit older. And I look back and I think, oh, that was quite a traumatic operation. And it's nice to see it's changing. So yeah, it's good.
Yes, I like to think so too. And there's some nuances about the screws and the rods and how I do things. And I've learned this and shimmied that and scoot, what when I don't put in screws at every level. You know, when I see someone, and I was like, oh, that guy wasn't thinking, you know, so I like that people are thinking, and like that people
Yeah.
are having conversations, and I like it when people go, I felt really good about it. I knew I was at the right place, making the right decision with the right guy, getting the right surgery.
Yeah, and that'll make you feel better afterwards, I should imagine, just in terms of pain and confidence and all that kind of thing. Much better outcome.
Oh
Yeah.
yeah.
Yeah.